Good afternoon. I'm Thomas Kent. I'm a stroke neurologist and professor at Texas A&M's Biosciences Institute in Houston. My clinical appointment is with the Department of Neurology here at Houston Methodist Hospital. I'm pleased to have been asked to moderate this session on the future of stroke is prevention. Our presenters will speak for about 15 minutes and then we'll have about 5 minutes of discussion after each presentation. Our first speaker is Jonathan Wiese. Jonathan earned his nursing degree from the University of Iowa, then worked at Houston Methodist as a floor nurse in a stroke overflow unit for 2 years. He then transitioned as a clinical research nurse in the stroke division. He then earned his NP certification and is focusing his work on secondary stroke prevention and lipidology in the outpatient stroke and lipid clinic. He's involved in the clinical research and education aspects of the Houston Methodist stroke program. His talk today will be on the future of stroke prevention is advanced lipid management in the neurology clinic. Jonathan?
Thank you, Dr. Kent, for that nice introduction. And it's a real pleasure to be here today to present to you the future of stroke prevention in lipid management. So today I'd like to discuss with you the idea of controlling cholesterol, reducing cholesterol for prevention of ischemic stroke. In particular, I'd like to focus on atherogenic lipoprotein, LDL, or low-density lipoprotein, and triglyceride level, and reducing the risk reduction for atherosclerotic cardiovascular disease. And we all know the 2018 ASA stroke guidelines that were presented in 2018 at the stroke conference. In 2019, they provided an update to these guidelines. And in particular, there was a new portion that was dedicated to the treatment of hyperlipidemia. These guidelines have come from the 2018 American Heart Association, American College of Cardiology and National Lipid Association guideline on management of blood cholesterol. And this is now embedded into the 2019 update for the stroke guidelines. I really like this cartoon here. I think it is a great reflection of where we are in lipidology, in cardiovascular and cerebrovascular risk reduction within the past 15 years. We have now 15 years of evidence-based practice and data that supports a lowering LDL. And patients may be confused by this, and so I think it's our job as practitioners to really present the data and show them and be able to give them the best recommendations for lipid management. Now, coming from the 2018 guidelines for lipid management, I like to reference this decision tree table that looks at patients with clinical atherosclerotic cardiovascular disease. And this is ASCVD would be patients with TIA, ischemic stroke, PAD, and acute coronary syndromes. And within the clinical ASCVD, we can further stratify patients into being not very high risk and those being very high risk. And who are the very high risk patients? These patients here I've highlighted to the right could be those who have a major ASCVD event and multiple major events as listed as above, including a history of ischemic stroke, which would be our population, or could be one major ASCVD event and multiple high-risk conditions. Once you have stratified your patient into a not very high risk or very high risk category, you can follow that decision tree to help look at the guidelines to help with treatment management for lipidology. And this slide here focuses on the effects of therapy on lipoprotein metabolism. And with the guidelines, we're looking specifically at LDL reduction, looking at statins, Zettamibe, and PCSK9 inhibitors. And in addition to that, we are looking at triglyceride level reduction, in particular fibric acids and long-chain omega-3 fatty acids for ultimate risk reduction of atherosclerotic cardiovascular disease. And we'll discuss the data here. In terms of statin intensity, the guidelines outline that a high-intensity statin or a moderate intensity statin, if a high intensity statin is not tolerated, is recommended. And I really like to use this table here for looking at the differences in high intensity versus moderate intensity. Atorvastatin 40 to 80, rosuvastatin 20 to 40 as high intensity therapy, which lowers LDL by on average more than 50%, as compared to the moderate intensity 30 to 50%, and then onwards to low intensity. And I use this table just as a reference for patient management and treatment in finding a therapy that might be beneficial for LDL reduction. Now, the statin trial data that we have comes from a 2006 pivotal trial in stroke prevention that was published in the New England Journal of Medicine. And in this trial, more than 4,000 subjects had a hemorrhagic or ischemic stroke, or TIA, within 1 to 6 months of enrollment, with a baseline LDL of 100 to 190. And they were randomized to the treatment arm of atorvastatin 80 milligrams or placebo, with the primary outcome looking at the time from randomization to the first occurrence of a non-fatal or fatal stroke. And what we saw was that in the treatment arm, atorvastatin, high-intensity statin, a lower LDL reduction of 73 versus a mean average of 129 in the control group, and a reduction of ischemic stroke, 218 versus 274 in the control group. And that related to a relative risk reduction of 16% for the primary outcome point. And further demonstrated here in the data from this study, the largest reduction in fatal stroke, followed by major adverse cardiovascular events, then TIA and non-fatal stroke here. So really great data in reducing the risk of ischemic stroke. Now, looking at Zettamibe, this is also now embedded into the guidelines, and several points here for use of Zettamibe, in addition to maximum tolerated statin for LDL reduction less than 70. And where does this data come from? We see it here from the 2015 study that was published in the New England Journal of Medicine, the Improve It study, where more than 18,000 patients were hospitalized with acute coronary syndrome. Again, this is not a stroke study, but a heart study, whose baseline LDL was 50 to 100 if they were on low-intensity statin, up to 125 if they were on no statin at all. And the treatment arm included simvastatin, moderate intensity statin with Zettamibe 10 milligrams versus a moderate intensity statin alone. This was a 7-year trial. The average LDL reduction in the treatment arm was average 53 LDL. This is milligrams per deciliter versus 69.5. And the primary outcome was CV mortality, major CV event or non-fatal stroke reduction. And the absolute risk reduction was 2%, which correlated to a number needed to treat of 50. So very good outcome there. And you can see here on the Kaplan-Meier curve where the separation exists between statin and Zettamibe and moderate statin alone. Now, looking at ischemic stroke outcome, we can look at the treatment arm of 3.4% versus the placebo of 4.1%, with clinically significant reduction of ischemic stroke with the Zettamibe arm. In terms of PCSK9 inhibitor, we do have some guidelines here demonstrating addition of PCSK9 inhibitor in addition to maximally tolerated statin with or without Zettamibe. And the data here comes from our PCSK9 inhibitors, which include the Odyssey trial looking at Praluent, which is a combination of 2 doses, a lower and a high dose, where patients enrolled had a recent coronary event within 12 months of enrollment. And the outcomes showed a relative risk reduction of 25% of ischemic stroke, 15% reduction in MI, and 14% mortality reduction. Similar results with the 4-year trial, Repatha, which is a single dose every 2 weeks or once monthly. And patients enrolled in the study had a relative risk reduction of 21% of ischemic stroke, 27% heart attack, and however, there was no mortality difference. And in terms of the pure LDL reduction, I really like looking at this graph here, where you can see the difference on treatment where LDL is significantly reduced. And if going back to that table that I discussed with you earlier, the PCSK9 inhibitor really is a therapy for maximum LDL reduction as compared to some of the other therapy options that are available. Now, what these studies correlate to is seen here in this meta-analysis by Collins in the Lancet in 2018, which shows that looking here on the x-axis, the median 1-year LDL difference between treatment groups, if we look here in the middle here, 1 millimole per liter is equivalent to about 18 milligrams per deciliter. And the major vascular event reduction on the y-axis to the left is proportional to the absolute LDL reduction. And this is demonstrated through the various clinical trials. And I really like this as a graph to really demonstrate the LDL theory in risk reduction in terms of the lower the better. Now, in terms of triglyceride level and how that may benefit atherosclerotic cardiovascular risk reduction, we first have information from the JELIS trial, which showed some promising results. And this is using a highly purified EPA medication that was studied just in Japan, and it showed a 19% reduction of coronary events. Now, this is a study that used a compound that's not approved in the US, but it showed some promising results leading to the Reduce It trial, where, and this is published in the New England Journal of Medicine in 2019, using icosapent ethyl 4 grams per day, which is 2 1-gram capsules twice daily with a statin versus statin alone. And in this trial, it showed an absolute risk reduction of 4.8% in 5 years, correlating to a number needed to treat of 21. And this is the curve here showing the treatment arm separation from placebo. And it is FDA-approved prescription for pure EPA. There was a reduction in triglyceride of about 18% for patients in the trial. And this is a medication that doesn't significantly raise the LDL level. And it's noted that the degree of benefit is consistent across the baseline triglyceride levels of subjects who were in the study, which suggested that there was a benefit mediated through mechanisms outside of triglyceride lowering effects. Now, this is not in the guidelines for stroke or the lipid guidelines, but the NLA, the National Lipid Association, has provided a position statement supporting the use of icosapent ethyl for reduction of atherosclerotic cardiovascular disease. I will note that in the study, the Reduce It study trial, there was an increased hospitalization rate for atrial fibrillation and atrial flutter, which was 3.1% in the treatment arm compared to 2.1% in the control arm. So something worth considering. If we put these trials together and kind of look at an overview, I really like this article here published in Stroke by Hackham and Hegel that demonstrate the effect on ischemic stroke, starting with statin versus control, a relative risk reduction of 20%, and moving down the table. This just nicely, succinctly summarizes the benefit with the therapies and the effect on reducing ischemic stroke. Now, there are other new therapies on the horizon. Just this year, 2020, last year, bempedoic acid is now available to prescribe for patients, and it has a different mechanism of action than the other medications that we've talked about. It's an inhibitor of ATP citrate lyase, which inhibits cholesterol synthesis. It comes in a couple of different options. One is called bempedoic acid alone, or Nexletol. The other is bempedoic acid plus Zettamibe, or Nexlizet. And there have been a couple of studies, randomized controlled studies, that really have demonstrated the effectiveness in LDL lowering when it comes to use of this medication when added to a maximally tolerated statin. And it's important to note that this is a medication that could be added to a statin or PCSK9 inhibitor, however, as needed for your patient management. And I will say that there has been a systematic review and meta-analysis showing that bempedoic acid was associated with a lower risk of cardiovascular events in diabetes. However, I think we need a more follow-up trials and more clinical trials to show the effect on ischemic stroke risk reduction and further atherosclerotic cardiovascular disease risk reduction. But I like to show that this is a medication that could be used as a tool in your toolbox when it comes to lowering LDL and being able to have that as an option. Other agents on the horizon, just this week, January 2021, I saw an article where there is a medication that's being tested in a primate population that is a once-and-done single-dose therapy for long-term LDL reduction. And they've already been at 6-month follow-up in this primate population where they've seen sustained LDL reductions. Now, this maybe kind of dovetails on the keynote speaker's discussion on gene editing therapy. This is kind of the mechanism of action behind this, and really for inherited high cholesterol or heterozygous familial hypercholesterolemia. So I think there's certainly some room for additional agents for cholesterol lowering. Here are some key points that I outlined here in my discussion, and really emphasizing the use of therapies for LDL reduction and considering triglyceride lowering therapies for ASCVD risk reduction as well. And just in summary, there's various options, and we should use these tools in our toolbox. And here are my references, and thank you for your attention today.
So thank you very much for that excellent presentation. I do have a couple questions. So the effect on reducing ischemic stroke looked pretty consistent, but some of that is moderated by a risk of intracerebral hemorrhage. And so I'm wondering, what's the thinking in terms of, are there any contraindications for putting patients on these lipid therapies? And I'm thinking specifically about the newest ones, as well.
That's a great question, Dr. Kent, and thank you for that. I do want to emphasize that this discussion and the guidelines are really for ischemic stroke, atherothrombotic, or lacunar stroke subtype reduction, and not really touching on hemorrhagic stroke population. But we do have some data based on the hemorrhagic stroke population. And the data first comes from the Sparkle trial, which showed, as I mentioned, the inclusion criteria for patients in that trial included hemorrhagic stroke. And in the hemorrhagic stroke population, there was in the trial itself, there was a clinically significant risk for hemorrhagic stroke on the treatment arm of high-intensity statin. But I think it's also to note as well in the discussion for this study that patients who had hemorrhagic stroke were more likely to have a recurrent hemorrhagic stroke and have a risk factor of high blood pressure. And on further analysis of the study, the patients who have hemorrhagic stroke and on high-intensity statin showed not significant reduction in LDL. In other words, there could be an issue of non-compliance for that population. And we have additional data on hemorrhagic stroke in the other trials as well. With the Improve It study, there was an increased risk of hemorrhagic stroke on the treatment arm, Zettamibe and moderate intensity statin. And in that study, it was not clinically significant, but there was an increased hemorrhagic rate. With the PCSK9 inhibitors, for the Odyssey trial, there was not an increased risk of hemorrhagic stroke. In the Repatha study, there was an increased risk of hemorrhagic stroke, not clinically significant. But I think the takeaway there is that certainly you have to provide and use clinical judgment and caution for your hemorrhagic population. And maybe if there's an incidence of microbleeds, multiple microbleeds, I would use caution and clinical judgment. And even in a population of cerebral amyloid angiopathy. So I think it's something that we certainly should pay attention to as well.
Great. Okay. Quick question, quick answer.
Yes.
What's it like to be a nurse practitioner in a stroke clinic?
I love it. I think I've had a really unique opportunity here at Houston Methodist with all my stroke physician colleagues and nurse practitioner colleagues. And it's just been a really great opportunity to be able to be part of the team and to really focus on lipid management in the stroke population. So it's been amazing.
All right. Well, thank you very much.
Thank you.